Good afternoon, everybody. I guess while they're transitioning, I'll just go ahead and introduce myself and a little bit about my topic, I guess our gynecologic portion of the afternoon. So I am Dr. Christina Pardo. I am, currently obstetrician gynecologist at Weill Cornell Medicine and medical director for the women's health practice. I'm also proudly a part of the School of Public Health here at Downstate in the Department of Community Health Sciences. I think one more point of pride I'd like to say for myself, I think I'm connected to all the different elements that have put this together. So thank you for having me here today. I'm a proud graduate of the Downstate OB/GYN residency program and proud to have partnered with Health First on many initiatives. And last but not least, I am an alumnus of Howard University. I always say the four most important years of my life. So thank you for bringing us all together here today. And so I'm going to talk about the global burden of disease for benign gynecologic conditions. Hopefully, I can share the importance of gynecologic conditions, not just obviously within our world of obstetrics and gynecology, but for all providers. And I don't have any disclosures relevant to this presentation. My objectives for today to highlight the ways in which benign gynecologic conditions significantly contribute to the global burden of disease, define what are benign gynecologic conditions, review those inequities both at the global aspect and our local communities, and what are the social and medical burden of disease related to these conditions. So the global burden of disease is a comprehensive effort that was initiated to measure the health of populations across the globe. It studies mortality, morbidity, and risk factors, as well as health systems. The key measures that are used for to evaluate global burden of disease are one called the DALYs, Disability Adjusted Life Years, which quantifies the total years of life lost due to death and disability. Second, years of life loss, which measures the years of life lost due to premature mortality. And years lived with disability, measure the years of life lived with disability or health conditions. I don't know if I move this mouse so you can see it on the screen. Do we have a pointer? No? And so the graphs, the maps that you see on the right side, or I guess the left side, shows you the number of data sources in the... This one? Okay, I will do that. Let's see, maybe I can move this way. Great. What you see here in these maps are the number of data sources from each country. So obviously, unsurprisingly, countries that are considered quote unquote high income will have higher number of data sources versus the historically impoverished countries. And so when we look at the global ranking of the DALYs across for women specifically, we see that women have higher burden of morbidity-driven conditions. So this is a graphic that shows the morbidity for females versus male. And while you see, ischemic heart disease, and stroke at the top, you see more of a prevalence of the morbidity related conditions for women, most notably low back pain, depressive disorders, and headache. As we moved really towards looking at women's health and gynecology, I really want to paint the picture that, or hopefully the message that we'll send in looking at women's health and gynecologic conditions from a life course approach to women's health. Oftentimes, women's health is viewed around very reproductive health, specific time periods within a woman's life, but really looking at a life course that incorporates a different aspects of life, how that contributes to not just gynecologic health, but also the reverse, how the gynecologic health also impacts the chronic health disease risk. So as global burden of disease for gynecologic conditions, among non-communicable diseases in women of reproductive age, gynecologic conditions are ranked second worldwide for the disability-adjusted life years. So within the field of global health, we know that over the past couple of decades, there's been a trend moving away from where infectious diseases were at the top and now moving more towards non-communicable diseases as there's been more advancements in the management and access to HIV/AIDS and other infectious disease conditions. And unfortunately, the progress in reducing that burden related to gynecologic diseases has not met the target that was set for those. And some of the things, we'll go into more detail, but at the high level, some of the things that contribute to that is just the nature of gynecologic conditions as well. So there tends to be more of an insidious onset. There is a higher prevalence and oftentimes maybe just an acceptance of conditions, can have easy recurrence and often do span the entire life cycle for women. As we look at comparing the global burden disease from benign gynecologic conditions based on stratification of the type of country. So at the global level, it's usually divided between, high income or more resourced countries versus impoverished countries or have considered to be lower or middle income countries. So we see that for the more resource countries, at least the burden of disease for gynecologic conditions is less, 3.95%, versus lower impoverished countries, which is at 5%. And what's important, so the impoverished, I don't like to say low income, the impoverished countries do have a higher burden, but what's important about this, it's not about, where they have a higher rate of certain conditions. It's the burden related to the reduced access to care and services related to those conditions. So we'll take our time to just define gynecologic conditions. Again, just to create a neutral space for everybody. I know not everybody is lucky enough to be a gynecologist, so we'll kind of level the playing field. So benign gynecologic conditions are non-cancerous conditions of the gynecologic system. So we have obviously the ovary, the fallopian tube, the uterus, the cervix, and the vagina, not pictured here as external, where you have the vulvar. And the benign gynecologic conditions include fibroids, PCOS, infertility, genital prolapse, endometriosis, miscarriage and abortion, ectopic pregnancy, pelvic inflammatory disease, and other, which is a large kind of catch-all. That includes menstrual and non-menstrual conditions. So the menstrual conditions including abnormal uterine bleeding, all the way to the menopause and perimenopause conditions, and the non-menstrual conditions including vaginitis, breast conditions, non-inflammatory conditions of the gynecologic tract, endometrial hyperplasia, and non-inflammatory disorders of the cervical and vaginal disorders. And again, just to give, this is like everything within obstetrics and gynecology. So everything that we do within gynecology, the symptoms that relate to gynecologic conditions and also how we treat really go between this graph and the next one that I'm going to show. This is our menstrual cycle, so this is the physiologic aspect of it, and the way, the ovary develops within a menstrual cycle and ovulation, and then what happens when you don't have a pregnancy following that time point. The hormones, the changes in our hormones within the menstrual cycle. So from a physiologic perspective, a lot of both the symptoms and the interventions are related to controlling this right here within the physiologic aspects of gynecologic conditions, and not just that, towards infertility and also preventing pregnancy. And so when we talk about the physical, the anatomic contributions to causes of gynecologic conditions, that's where we see everything on this graphic here, where we see the uterus, and where you can have malignancy, fibroids, myoma, adenomyosis, which is when the lining of the uterus, the endometrium, can migrate into the wall of the uterus. Uterine polyp, which is a growth within the lining of the uterus. Coagulopathy, which is related to, obviously that can contribute to heavy menstrual bleeding. The ovulatory dysfunction, which again goes to our previous graph, the physiologic components of the gynecologic system. Iatrogenic, so if you have a foreign body like an IUD, that contributes to gynecologic condition. So over the past years, there's been more of a focus of evaluating what that actually translates to, or documenting the global burden of gynecologic conditions. And so these graphs kind of show this particular effort in really detailing the impact of gynecologic conditions. And what they found is that other gynecologic conditions contribute to most of the burden for gynecologic conditions, and that is in both high-resource countries and impoverished countries. What you see within the impoverished countries, you have the increased percentage or the burden of that large catchment of other gynecologic conditions. Also, following that, you will see endometriosis, uterine fibroids, PCOS, which I'll go into a little bit further detail. When you now look at it based on the age group, unsurprisingly, we see the highest burden is going to be around that reproductive age group, and starts to decrease from that point, even for higher resource countries, for 70 plus. They didn't even have a figure for that. Again, without anything that directly says correlates to this, but it may be related to the access to resources and treatments in more resourced setting. Surprisingly, also, the benign gynecologic conditions as it relates to now morbidity, in total, has higher burden for women compared to HIV, malaria, and TB combined for the reproductive age group. So we see here, for example, in impoverished countries, we see the pink being the benign gynecologic conditions, and HIV/AIDS here in the maroon. So as a combined, all of the gynecologic conditions have a higher burden of disability than the HIV/AIDS, malaria, and tuberculosis. And we see that across the spectrum here. And this is just detailing that, comparing the across the age groups. So if the traditional reproductive age, 15 to 49, and going up from that point. And unsurprisingly, once you get to age 70 and up, you see that the burden related to benign gynecologic conditions decrease as do with the other conditions. This is just another way to demonstrate it. This particular study evaluated not just the benign gynecologic conditions, but they also included some of the gynecologic malignancies when looking at DALYs specifically. And so, and they for each of the different regions, they kind of ranked the contribution towards the disability for that particular region. And so HIV/AIDS, unsurprisingly, is number one for many of them, but not all. And so you see, it kind of goes between HIV/AIDS and other gynecologic conditions. However, many of the other underneath that are gynecologic-related conditions that's contributing to the morbidity. And this is just showing the global burden from gynecologic conditions from a global aspect, the contribution to morbidity. Another way that they were demonstrating this, again, showing the different conditions, including the gynecologic malignancies, HIV/AIDS, sexually transmitted infections, and they added into this graphic really detailing the differences based on the age. So in this particular, which was on the top row, which is focusing on DALYs, we see that as we are moving from HIV/AIDS to more the malignancy and conditions that usually start to have a presence beyond the reproductive age. We start to see the increase in uterine fibroids, genital prolapse, and the malignancies. So to bring it to the United States, there has been, thankfully, as we all know, increased focus on health disparities, including within obstetrics and gynecology. So this is a really great committee statement that was published by the American College of Obstetrics and Gynecology on racial and ethnic inequities within obstetrics and gynecology. We most often obviously hear about maternal mortality, which is unacceptable and important. But what was also often lost with that is the disparities within gynecologic conditions. So we've come a long way from, initially it was always infant mortality, and then we started talking about mom and maternal mortality, and now we're kind of looking at as the woman in total. So, unsurprisingly, we see the disparities among many conditions within obstetrics and gynecology. I'm going to take a deep dive on some of the conditions just so we can understand conceptually what the impact of a global burden of disease, not just on an individual, but on an actual system. So when it relates to fibroid uterus, which affects about 70% of women who identify as Caucasian and 80% of women of African ancestry, it is considered the most common benign tumor of the female reproductive system. And now when we look at the burden within a system, in the reproductive age, about 30% of hospitalizations, they account for 30% of hospitalizations related to gynecologic disease and are the reason for about 40 to 60% of hysterectomies. And at the health system level, this contributes to annual income loss caused by uterine fibroids in the United States was higher than the total treatment costs for a breast, a colon, or ovarian cancer. And if we look at it from a global picture, the burden for uterine fibroids varies widely around the world, and a lot of that contributes to socioeconomic status and population structure. In 2019, higher resource countries had the highest age standardized incidence rates. And again, that's not because the actual prevalence is higher, but it's also related to what is accessible in the community, having adequate medical resources and health systems to actually be able to diagnose those conditions. So even though there's a higher documented prevalence, still the impoverished nations had the higher rates of disability related to fibroid uterus. So to move to PCOS, polycystic ovarian syndrome, which is a complex syndrome that includes metabolic, reproductive issues related to hormonal imbalance. This condition is probably the most connected to a lot of our chronic medical conditions like hypertension. In the presentation just before mine, the symptoms are irregular periods, androgen excess, and is the leading cause of infertility. And when we look at the economic burden of PCOS, just in the United States, it is estimated to exceed 15 billion. Direct costs related to diagnosis and treatment, indirect long-term health complications, mental health disorders, and reduce productivity. And there has been noted correlation with mental health conditions with PCOS. And I will say, as a gynecologist, this is really one of the most challenging conditions to manage or to support your patients, because often there isn't, a clear, there isn't a cure per se or treatment that works, across the board. So it really requires a lot of counseling and support and helping the patient to navigate their diagnosis, which is very similar also with endometriosis, which affects about 10% of reproductive age women and girls. It is a chronic disease associated with severe life-impacting pain, painful intercourse, bowel and bladder issues, and chronic pelvic pain. There is no cure, similar to the PCOS, and treatment is really aimed to controlling the symptoms. And again, this symptom burden that many women are experiencing leads to a total economic burden of 78 to 119 billion billion annually. As we now try to look into what does that mean for our communities from a disparities standpoint, and especially our communities here where we have a large population of foreign-born individuals, as when studies that are done nationally, especially for conditions like this, we know that for those who are identified Black or African American are usually a combination of several different subsets within that, so it makes it harder to understand the way conditions may present or the best way or the symptomatology or the best way to treat within different populations. So it makes it difficult, limited data for subgroups within the overall Black population. So as I try to really get a little deeper dive than what I just showed, especially for our Black and immigrant population, there are a few studies that evaluate gynecologic disparities specifically among Afro-Caribbean populations, and much of those are really within the malignancies, endometrial, breast, and cervical cancer. But when they did, unsurprisingly, there were disparities that were seen. So this particular study that was done in Miami, which, similar kind of population to what we have here, found that compared to U.S.-born Black women, Jamaican and Haitian-born Black women were more likely to have higher grade histology, present with more advanced disease, and receive chemotherapy. And also that Haitian-born women in particular had worse overall survival outcomes. And we all know that's not related to biology. A lot of that often is the access, and also for the cultural aspects and the comfort with receiving care in different settings. And of course, the issues surrounding being having immigrant status and barriers that may play. And I couldn't do a presentation without talking about maternal health disparities just a little bit, based on the work that I do here in Brooklyn. And so these disparities, obviously, we see within maternal health. And the New York City Department of Health, as we saw, Dr. Easterling has done a lot of great job. And what they did is they really disaggregated the data. So we were really able to see disparities, not just for a total population or a total racial group, but subgroups. And so one thing that was quite notable as it relates to severe maternal morbidity is that Black foreign-born women have had the highest risk of pregnancy complications. They didn't have the highest numbers, but they did have the highest risk of pregnancy complications, with those born in Haiti being at the top. And if you haven't read this publication that just came out from the Department of Health just a couple months ago, I really encourage you to read it. I added the QR code, so if you want to look it up, where they really did a phenomenal publication on the health of immigrants in New York City. And again, we see the disparities there within our perinatal health populations, with, unfortunately, Jamaica and Haiti and Guyana being at the bottom of the list as in those receiving timely care. And with infant mortality, we see the reverse: Haiti, Jamaica, and Guyana having the highest risk of infant mortality here in New York City. So, back to our gynecologic care and summarizing the disparities in access to both obstetrics and gynecologic care. We know that racial and socioeconomic inequities influence access to diagnosis, treatment options, and health outcomes here within our communities nationally and globally. But now when we get to the patient-specific aspect of it, it has been documented that women are less likely to participate in shared decision-making, reduced access to care, information, and services for both obstetric and gynecologic conditions and procedures. Within the obstetrics side of things, we hear that a lot around cesarean deliveries, and then obviously for this aspect and some feeling, being pushed to have one particular decision to manage their gynecologic condition. And then nationally and globally, disparities in access to gynecologic care and minimally invasive surgical options. So this is what really drives the morbidity aspect. So now you have fibroid uterus or whichever condition that's really contributing your daily life, and you don't have access to the surgical management to it. And perhaps even if you have access to surgical management, but not to minimally invasive, that can have the reduced impact on your overall life. And all of these things contribute to the delayed diagnosis and treatment, higher rates from the mortality rates from gynecologic cancers, underrepresentation in fertility treatments, and socioeconomic barriers to preventative care. So hopefully at the time where some of these conditions can be managed medically. And here in New York and across the United States, obviously that access to primary care facilities really is diminished, especially depending on where you live within the city and where you live across the United States. And when we add the immigrant and cultural aspect to it, we see that, of course, we know that race plays a role in our access to care and also the way we're received when we are attempting to receive care. And then we add the immigrant or foreign-born aspect to it. So the difficulty in navigating system, perhaps there's a language barrier, fear, especially we're, unfortunately are experiencing more of that now, and also a distrust of the care. And so this intersectionality and levels of barriers of care are most prominent, especially in communities here in central Brooklyn. And this translates to the social and medical burden. Now when we talk about women and gynecologic conditions, unfortunately, some of it related to the nature of the condition, having a chronic component to it that impacts the functional impairment, the ability to live, to care for your children, to be able to work, delays in diagnosis and treatment, economic costs, not just for you as an individual, but for an entire system, the mental health impact, and stigma. So unfortunately, there has always been a stigma around reproductive conditions and gynecologic conditions, which can make it harder for women to seek care. So, in my, final message, I really hope that in pursuing a life course aspect to women's health, we can begin to reduce the stigma so people are more comfortable to address their gynecologic conditions early, while also we're working to improve the access to care. This is a big driver for gender inequality. Again, chronic pain, stigma related to accessing care related to these conditions. There has been an increase in advocacy. You see this especially around menstrual inequity. You see the sign here, end the period poverty. So this is not just globally. Even here in New York City, there's a big focus on menstrual equity, for example, in homeless shelters and different settings, and really pushing for holistic and life course care for women. And I can't end without, one of our great pioneers within our community, leaving us with some inspiration. And thank you for having me.